All right. Well, let's begin. Good morning. I'm Lorraine Crampton. I've been the organizer for this year's symposium. I'm delighted that you're here. I want to thank Dr. Lauren Brown and Healthy Seminars for their role in making this an excellent day and providing it online, as well as helping us to organize it live for you. Yesterday was great fun, and I trust today will be equally informative and helpful. I have the great pleasure this morning of introducing to you first Dr. Dao-Xing Ni, who all of you know and heard his speech yesterday. And Dr. Dao?
Good morning. Hello, everyone. It's great to see everyone. I have the fortunate mean today to introduce Dr. Richard Mars. He really doesn't need much introduction at all. He is well renowned not just locally, but also globally. He is one of these physicians who has done pioneer work in this field in reproductive medicine. I think he's one of the IVF surgeon, IVF specialists who has done ART in assisted reproductive technology in the Western United States. In 1983, when I started my practice, and as I started working on some of the difficult patients of trying to get pregnant, already I heard about Dr. Mars at that time. Patient always say, "Hey, Doc, you need to check this guy out." I say, absolutely, when I get a chance. But I'm actually a little bit afraid because at that time, you need to recognize this is really early days where, Chinese medicine people is not as much respected. And so, you either have a lot of time, either physician either is really, really for you or really, really against you. There's nobody in the middle. So in that sense, it's like, okay, I don't know. But anyway, eventually, we have some shared patient. He was very generous and referred me a patient or two to start and really take me really under his wings to really see some light on what he's doing. And I'm really just totally respectful of him. And he not only did that when I was trying to apply for membership at the Pacific Fertility Society at that time. Now it's called the Pacific Reproductive Medicine Society, I think that's called. At that time, only physicians can really apply. He actually wrote me a letter, sponsored me into the organization. So I will never forget that. So I really appreciate it. And we really just a great opportunity today to hear this topic. He has so many years of experience. And I can tell you, for the poor responders, this is a guy that you want to send the patients to. He knows so much about the poor responder. He nudged them along, and there's just so much thing that he can do with them. So anyway, so without further ado, Dr. Richard Mars. Thank you.
Is that okay now? There we go. I gotta have my hands free. I talk with my hands. Thank you, Dr. Ni. It's my pleasure to be here. I appreciate the opportunity to speak. I think this is a wonderful combination of clinical medicine and traditional Chinese medicine, and I believe strongly in that combination in patient care. Not just in reproductive medicine, but in general. So I want to thank Lorraine and everybody at Yosan that puts this together and allows me some time to talk about some things that I'm interested in you guys have to deal with just like I do. These are difficult patients, both from a medical, psychological standpoint, and we have to understand what's going on within their physiologic systems when we determine how we're going to approach them. The poor responder, diminished ovarian reserve, a lot of terms for these patients, but the bottom line is that these are patients that don't have the same number of antral follicle activity as their peer group, age group should have. I wish I had time to go back and talk about how the ovary makes eggs and when those eggs come up and all that stuff, but we'll have to do that when we have all day. The things you need to remember about these patients before you start talking about how to treat them is what goes on in the normal process, and that's between the pituitary, anterior pituitary, and the ovarian stroma, ovarian follicle, granulosa cells, theca cells. When I did my first IVF case in 1981, we really didn't have much idea about what we were doing. I had no idea what I was doing, but we did understand a little bit about ovarian follicles, not to the extent we have today. But this is important. The two-cell theory, FSH activity, LH activity, the interaction between granulosa and theca cells is important to know how it works when it's working properly, as far as steroid hormone production, androgen production, and how that affects follicle growth. Because the natural cycle of the human is a combination of FSH pulses, and then later on more activity with LH-FSH combination. And once you understand what goes on in the development of one follicle in a natural cycle, then you can kind of use that information as you decide what ways you can maybe stimulate multiple follicle development. This shows on a timeline, day 0 is the menstrual period. Before the menstrual period occurs, FSH pulses are necessary for final recruitment and activation of follicles that started 60 to 90 days before that point in time. So those follicles came out of their resting phase in the ovary 60 to 90 days, and a few days before the menstrual period became activated antral follicles that we can then see on the second day of the cycle when we do an ultrasound and we can do a follicle count and that sort of thing. But low pulses of FSH are important. At the beginning of the cycle, FSH pulses stay the same frequency, but the amount of FSH is higher. And that's what selects out a follicle out of a group of follicles in the human. Mammals are different. Lower mammals have 20 follicles. They grow 20 eggs fertilized, 20 blastocysts, 20 babies. I thought when we did our animal studies, we'd have no problem with the human because everything worked in the mammals. We were wrong. Mammals are different than humans. LH pulses come in later. Once the follicle kind of gets established, LH pulse and FSH are important to finish the maturity of that single follicle, and then an LH surge causes it to ovulate. That's the natural cycle. FSH, LH, estradiol, feedback, the two-cell theory. When we first started stimulating to override the natural follicle, we basically, well, the first baby I had was with clomid alone, clomiphene citrate. 2 eggs, 1 embryo, 1 baby. And that was about in the first 25 cycles we did of IVF in 1981, sorry. What we did basically was just increase pulsatility amount of FSH and got more than 1 egg in those patients with clomid alone. Today, we're a lot more aggressive. Some of that's good, some of it's not. The things that we kind of follow when we're talking about poor ovarian reserve, poor ovarian response, are some of the things we learned as we went along. Steve Hillier is an amazing basic scientist. He pretty much worked out the FSH activity in the human granulosa cell and the follicle. He taught us that early follicle recruitment is dependent on FSH primarily, but as the follicle reaches about 10, 11, 12 millimeters, as it becomes an established follicle, whether you're talking about natural cycle or stimulated cycle, LH is important. Fleming showed that when no LH activity was present in a stimulated cycle, lower production of 17-beta estradiol per follicle growing was lower than when there was LH and FSH components driving that follicle to maturity. In fact, Follicle in the early 2000s actually published a couple of papers where he did not use FSH. He took patients and stimulated them only with HCG, which is an LH surrogate, and got follicles to grow and got eggs out of those follicles that actually fertilized. No FSH at all. But there was endogenous FSH in the system. So a lot of things were done in early 2000s, late 90s, and that was to try to figure out how the follicle worked and what we could and couldn't do to it. As we've dealt with poor ovarian responder patients, we learned some things along the way. The first problem, when you look at the literature with a poor ovarian response category, there was really no standard of what this patient was. What made a patient a poor ovarian responder, a diminished ovarian response? Certainly, you could see any pattern in the literature in the published data. Most often, these were patients that were older. They usually had smaller or fewer follicles on ultrasound. They used, a lot of times, they would have an abnormal E2-FSH balance, meaning their FSH was higher, or they came in with high E2 and indicating early follicle development before menstrual period began. When the AMH, anti-Mullerian hormone, came about, everybody started jumping on AMH. I don't use AMH as a determinant for clinical treatment. AMH can be affected by a lot of things. AMH is not the most accurate or reproducible clinical hormone marker. So the Europeans determine who they're going to stimulate and how much drug they're going to give them based solely on AMH. They don't need an ultrasound. So AMH is used different ways. I don't use it very much. The other factor was usually it was just patients have a decreased number of oocytes in prior IVF cycles. So these were all categorized as poor ovarian responder patients. So the literature was replete with articles. You'd see patients that were PORs. The publication said, well, we treated this with this stimulation. We got an average of 12 eggs per cycle. Well, that's not a poor ovarian responder. What we finally came about, the Bologna criteria was developed at an ESHRE meeting in 2010, 2011. And they sat down and said, we have to define poor ovarian responder patients. Otherwise, the literature is garbage. They said it had advanced maternal age, one criteria, previous cycle with 3 or less oocytes. We're talking about this is a true poor ovarian response category of patients. Abnormal reserve testing, few 5 to 7 antral follicles, or an AMH 0.5 to 1.1. The problem with AMH is so age dependent. If you've got a 40-year-old woman with a normal antral follicle number, she could have an AMH of 0.8 or 0.9, because at 40, 41, that's what you're going to see most of the time. And they've got a normal number for their age. So AMH is a little bit difficult to use, and that's why I don't use it. But anyway, this was what the Bologna criteria was defined as. It's being used today to standardize the data that comes out of POR patients. You have to have 2 out of the 3 of these criteria for a patient to be categorized as a poor ovarian responder. Then you can compare apples to apples when you're looking at literature comparisons of different stimulation protocols. We defined a long time ago. It seemed like right after I met Dr. Dow, I started seeing poor ovarian responders. And in those days, we didn't have real aggressive stimulations, but we just saw patients that just didn't respond. You'd give them 5 days of clomiphene citrate and they didn't even grow a single follicle. And you go, what's going on? So we started seeing these patients early on. And what we did was we defined our criteria in our center, whether it was at USC or when we moved out to California Fertility Partners. We looked at basal follicle number. How many follicles do you see on ultrasound on the 2nd day of the cycle? These are follicles that are 4, 5, 6 millimeters average diameter. If you see something that's 2 millimeters on day 2, and a lot of people do this and tell the patient, you've got 8 follicles, all active, they're 2 millimeters average. Those are just follicles that could have been inactive for sitting there. They could be who knows what. You've got to have a minimum size for a follicle to be countable. The other thing that we've used and defined and talked about over and over again is synchronization of the basal antral follicles. You can see a poor responder that's got 5 or 6 follicles, active follicles, which is great. If you've got one of those follicles that's 9 millimeters and the rest of them are 4, that's not so great. Because if you start your stimulation, you've got a lead follicle that takes off and you never can catch up the rest of the group. So synchrony is important. The things that we don't do, shouldn't do, we've told ourselves we can't do, you want to avoid anything that makes the follicles suppressed. In the old days when we were using Lupron downregulation schemes, our primary stimulation approach, that's the most suppressive treatment for a follicle. Depleting the pituitary of FSH and LH with Lupron and then holding them on that, stopping having their period. The follicles are very difficult to grow because you have to start from 0. There's no endogenous pituitary activity. Again, going back to that 2-cell theory. Birth control pills are not as suppressive as Lupron, but some patients are even more suppressed by birth control pills. So I really try to avoid birth control pills. Why would you use birth? Well, a lot of people use birth control pills to synchronize the follicles. So these are things to not do. And the other thing over the years, because we did a number of studies looking at amounts of stimulation drugs, gonadotropin doses, and when Dr. Stone and I did a lot of this in the 90s, we looked at per mature follicle how many units of gonadotropin were given to that patient to get this number of mature follicles, and what did the egg quality look like when we got it into the laboratory. The higher that ratio of gonadotropin per follicle per egg, the lower the quality, the lower the fertilization, and the lower the pregnancy rate. So we started using decreased amounts as much as possible. We're going to go into those protocols in a minute, but what did we do alongside of what we could do? We looked at, as Dr. Dow mentioned, we started working together, looking at